And hi, everybody. Welcome to Community Chats. Today is July 20th, and I am your host, Sandra Arevalo. I'm the Director of Community Health and Wellness at Montefiore. Today, we have a very, I don't even know how to describe, because you have so many titles, and he's a neurosurgeon, and that alone just sounds fantastic to me, Dr. Andrew Kobets. And he's going to be telling us a little bit more about what is it that he does. And Dr. Kobets, don't forget to let us know also where we can find you, where is your practice and all of that. And tell us a little bit about your job, because we actually were discussing this a little before we started today. And the things that Dr. Kobets does are truly amazing. And I'm sure that he's going to join us for more community chat. So it's a pleasure to get to know you, Dr. Kobets.
Absolutely. And it's an absolute pleasure to be here today. And I truly do appreciate the invitation. And it's a privilege to be able to talk a little bit about what I do. I think we wanted to just, get a sense of who I am, why am I qualified to be able to talk about this topic, and what information can I provide that will help you better take care of your child if something urgent happens to them, and what to do in those type of situations. But my name is Andrew Kobets. I was born and raised in Queens, New York. Didn't go far. I got my undergraduate degree from Johns Hopkins, and then went to medical school at Yale University and completed training there in 2012. It's astounding to me. It's already over a decade. And then I came to Montefiore Medical Center to be at one of the top institutions for neurosurgical care, specifically in pediatrics. And I trained under the great Dr. James Goodrich, who was, internationally renowned for his work in craniofacial deformity and management of children with calvaria or skull abnormalities, as well as other intracranial or abnormalities within the skull. And after completing a fellowship at Johns Hopkins in pediatric neurosurgery, I returned to Montefiore to take a position as an assistant professor of neurological surgery, and most recently was granted a promotion towards assistant professorship in pediatrics as well. I'm the neurosurgical director of our craniofacial center with Oren Tepper, our plastic surgery colleague, and an attending physician at Montefiore Medical Center and the University Hospital for the Albert Einstein College of Medicine. So I see many, many, many children, unfortunately, in the emergency room in my clinic that fall, that have injuries to their heads. And there is quite a big spectrum of when these injuries can have any lasting consequences for the child, when they won't, and knowing the difference of when to come into the emergency room and when to not, or when you can stay at home, I think is very, very important for parents, first-time parents for sure, so that you armed with the information to be able to understand what's going on within your child's head or on their skull at a time right after they have a severe head injury or even just a less severe injury. And understanding what to do then, I think, is very, very important to you be empowered with that information, but then also know who I am, that I'm always here, always available to be able to help you. And I will give my contact information at the end of the talk so that you don't ever feel like you're alone. I give out my personal contact information to nearly all of my patients. And, at first I was worried about 2,000 people having my cell phone and getting worried and calling about every little thing. But, my experience has been that when emergencies arise, I have the privilege of knowing about them first so I can work with the parents to expedite care as much as possible to save time. And that time saving really has a profound impact on what the outcome from that injury or whatever issue is going on can be. So I would encourage, at the end of the talk, please take down my contact information and know that I'm always available to help you and your family, even if we've never met. That's my job. So I do have offices up in Taxter Road in Elmsford, right over the bridge from you guys, and in the heart of the Bronx on Gun Hill Road at the main Moses division of Montefiore Medical Center. But all over the Bronx, I have other offices as well. In Eastchester, at Wakefield, I can see patients, and at White Plains Hospital as well. So know that wherever you are, I'm not too far and always available to help you. So let's get into the talk. Is it just a bump or severe head injury? What do you do when your child hits their head? So the objectives of the talk, as I was thinking about how to best present this in a very straightforward way, when I talk to my patients in clinic, I avoid at all costs using any kind of medical jargon. I do have to use some here, but I will explain it in detail so you are empowered with the knowledge of what it means, what to expect in different situations, and how you can assess your child. I mean, there's nothing secretive about different signs and symptoms that you can look out for to help us help you, essentially. So as we're talking about this, not only just having information in a very straightforward language that has no jargon in it, I also am very big on showing pictures to my patients. Obviously, pictures worth 1,000 words. Understanding what visually is going on is critical in terms of understanding kind of the conceptualization of what to do as a result. So we'll go through a number of pictures, and I will give you information on how to understand what each picture is meant to see and show, and what we do with that information. So, I start with just an overview. How common is this accidental head trauma in infants? How can it occur? What are the symptoms? When should children be brought into the hospital, which is a very critical component with the assessment of the symptoms? What happens at the hospital? Before you get there, what can you expect? What can you do? How can you advocate for the best care for your child? And then what are the consequences? What are the long-term ramifications of this accidental head trauma? What can you expect? And can children, despite having trauma, completely live normal lives afterwards? And, a short answer is yes, but it depends on the severity of that. So I think going through these will give us a very good sense overall of the topic. And, I want to encourage, if there are questions, I want to make this a little bit less formal. I want to be able to talk in the moment. If we save 10 questions for the end, we're not going to be in that part of the conversation where the question would be most relevant. So do not worry about stopping and asking questions. I want to make sure everybody's on the same page, everybody understands what we're talking about and what we can do to best care and assess these children. A little caveat too, we're talking specifically about accidental head trauma. That is, of course, in contrast to non-accidental head trauma, NAT. And non-accidental head trauma, for as nice of a word as we can say it, is a form of child abuse. So with abusive injuries, there's very characteristic patterns, very different presentations. We're not going to be talking about that today. I do testify in court sometimes to assess and to provide information for juries and for judges and courtrooms to best understand whether injuries could be the result of accidents or not, to help understand what could have happened to those children. But maybe we'll save that for another talk for another day. Today is just going to be accidental head trauma. Head trauma in general is one of the most common childhood injuries. It accounts for 600,000 emergency room department visits. That is an astounding number. 95,000 hospital admissions. So the difference between those two numbers shows that there's about 500,000, a majority of those patients, that go home afterwards. They don't necessarily have to be admitted. And of those 95,000 hospital admissions, there's about 550,000 hospital days that the children stay in the hospital afterwards. So while there's a fraction of the patients that present to the emergency room that actually get admitted, when they do get admitted, there's about a 6 or so day average of hospital admission. That doesn't mean that a minor injury would necessarily require the patient to stay in the hospital that long, but we get patients on the other end that do have very serious injuries that stay far longer than a week. So that kind of skews that average a little bit. Hospital care costs with these type of problems, $1 billion per year. It's an extremely large amount of resources that are needed to be able to manage these children and understand what's happening to them. And as a result, there have been many different guidelines and modifications to our previous management plans that allow us to understand who actually does need to stay in the hospital, who doesn't, where we can better allocate our resources. Death is very, very rare, but can occur with very, very severe injuries. And that's kind of where we come in, not just as a guidance for children who may have more minor injuries, but when we're needed, when neurosurgical intervention is required, in only about 2 out of 100,000, 2% of patients, 0.2% of patients, my apologies, those are the ones where we're really trying to prevent any serious mortality from occurring. And that's where we really jump to act as quickly as possible to provide the best outcomes for our patients and to prevent very serious outcomes. And that's not to say that if we can't intervene early, patients that do have very serious injuries can still survive, can still thrive, and can still return back to their neurological baseline. So that's why acting fast is one of the most paramount things that we can do for these children. So on the spectrum of accidental head trauma, we first start with minor blunt head trauma. So we'll talk about GCS, but that's the Glasgow Coma Scale, and it's just a measure of how alert the patient is and what kind of neurological function they have. It's out of 15 points, so 14 to 15 means that the patient is doing really well, maybe a little dazed, maybe a tiny bit out of it, but overall is neurologically fine. So they may hit their head, but no significant change in their neurological function, in their neurological state, how they're acting, and is one of the more mild, minor portions of the scale. We take one step up to mild traumatic brain injury. And when we talk about traumatic brain injury, there's enough force, there's enough trauma that the brain can be affected compared to head trauma, blunt head trauma, when not necessarily the brain is affected, the skull has done its job and prevented any of that force from the outside to come into the brain to cause any changes there. So the GCS score, their wakefulness score, and their neurological function can be in that same range, maybe 1 point lower. They did lose consciousness. LOC is loss of consciousness for less than 30 minutes, so temporary. The PTA of kind of their activity level and how they're feeling overall and sequelae afterwards are less than 24 hours. They may have mild confusion, they may have a seizure, some transient neurological changes can occur. So temporary, mild changes to the brain activity, which, a step up from just skull injury. And then we get into kind of the rest of it, the more severe end of acute accidental head trauma, where we call this term as a clinically important traumatic brain injury. So in the literature, it's CI-TBI. So that means that there's a significant change to the brain where there is a need for more intervention, whether it's medication, longer observation, different types of imaging studies, or in the worst case scenario, surgical intervention by myself and my colleagues. And this is where imaging or pictures of the head demonstrate actual brain injury, a fracture that's pushed down into the brain, a fracture at the base of the skull where the spinal fluid can leak out, and CSF leak, which is the cerebrospinal fluid leakage. These are clinically important, implying that they may need intervention, not necessarily surgery, but different types of treatments in the hospital. And this is our kind of spectrum of where we're working. We have a very narrow window of injuries that don't injure the brain, that don't need any major treatment, but then a very wide range beyond that where there could be a need for intervention afterwards. So how do we assess this issue in children and in infants? I'm going to focus on infants because much of what applies to the infants can be applied to children, but not vice versa. Children are able to relay information of what's going on internally, can tell us when they have pain, are able to understand and feel what's going on in their bodies a lot more than infants. Of course, they may not have the neurological, development and maturity to be able to, have perceptions in different parts of their bodies. And of course, when they're young enough, they can't tell us where their owies are. So clinical assessment, of course, is more difficult in babies. They can also be asymptomatic. They don't necessarily have to show symptoms where, a crying can, be the only thing that they show us when could be something more serious going on inside that an older child would be able to tell us about. The other major difference that we have to understand between infants and children is that infants have thinner skulls and their skulls are not completely closed and fused. And we'll talk about that in a little later, but that works kind of in two ways. One, the skull not being closed means the individual pieces of bone can move more than a closed and completely solid skull that older children and adults will have. But on the reverse of that, when you have a closed skull that an adult or a child will have, anything inside that's putting pressure is going to squeeze the brain against the inside of the skull, and that can really cause significant changes in their neurological function. So with babies, as a protective mechanism by their development and how we've evolved as a species over time, is that the skulls are not closed, so that if there is, God forbid, something inside their brain, inside their skull, inside their brain that is growing and putting pressure outward, the skull just expands. It's not pushing the brain against the inside of the skull, because the skull and the head can grow. And you may have seen children with large head sizes, could be from increased pressure or fluid in the brain. And as a result, infants might not have neurological changes because their skull can grow and accommodate anything inside that's pushing outward. Skull fractures or clinically important traumatic brain injuries can occur even with minor trauma with babies as well, because they are so fragile. So that is another difficulty in terms of understanding what's going on with infants. Another caveat is that, infants are much more susceptible to radiation from imaging, like a CAT scan, which has radiation to it, because their brains are far less developed than older children and adults. So that kind of changes what our options could be in terms of getting pictures of them and understanding what's going inside their heads, because we don't necessarily want to expose them to radiation if we don't absolutely have to, if there isn't an immediate change that we can see on the outside. So this throws a little wrench in the gear, makes it a little bit more difficult for us to understand and manage infants to the best of our ability in the emergency room in an acute setting. So how does accidental head trauma occur in infants and in children as well? Most often, overwhelmingly, 80% are from falls. And I unfortunately hear this story all the time. We were laying in bed, I fell asleep, baby rolled over and fell, and I was awakened by crying as they were on the floor. As children start to stand and start to walk, that they're teetering objects that at any point can fall over and hit their head. So a first-time or young parent is going to be extremely cautious about their baby as they start to stand and walk and become more trouble than we would like to deal with at certain times. Otherwise, on a changing table, I've had parents where they've been changing the baby and, accidentally the baby rolled over and fell off. Same thing for a sofa. Taking a baby in and out of a car in a baby seat. Unfortunately, that is also a story that I hear. And, when we're outside, concrete sidewalks are very concerning and dangerous in that setting. And then lastly, in strollers as well. Sometimes, rarely, but, it can be very heartbreaking for a parent to have an experience of a child or an infant falling out of their arms. It does happen. It doesn't mean at all that the parent is a bad parent, not at all whatsoever. But unfortunately, it can happen. And all of these details are very, very important for us to understand, what force could have been applied and where to the baby. And then, direct impact with an object, toys, furniture, etc. Those can also cause trauma to the baby or the child's head. So, the surface of the impact, whether hardwood floors, carpeted floors, and the height are critical pieces of information. So, if something happens, okay, it happened. We need to then figure out what to do next. We can't just dwell on this or that. We do that afterwards. What can be done in the future to prevent it from happening again? But in that moment, we need to act quickly to understand what we can do to best manage that child if they require management. And understanding and picking up all of these little details of information is critical for a parent, because they can relate that information to the emergency room doctor, the neurologist, and the neurosurgeon. And that will help us immensely to understand what kind of force could have been transmitted to the child and where. So this is a little bit of a busy slide, but it kind of goes through one of the large medical reviews on the topic, and just focus on the left column there on the causes. As we were talking about, fall-related injury, it can be seen in almost 80% of children. And then to lesser extent, falling from furniture, strollers, caregivers' arms, a baby carrier, impact with an object, struck by an object, and even collision with stationary objects. So, things that we talked about. But these really encompass, even in our largest series of patients, what the mechanisms for many of these injuries can be. So now we know what the mechanisms can be. Where does the injury happen? How can this accidental trauma be manifested? So, as we were looking at where babies fall, there is an overwhelming number of children that have injuries to their frontal bones, or the bones that make up our forehead. So with the head being much heavier than children's bodies, if they do fall, having the head kind of be more weighted down, have more weight to it, brings the child, brings the head closer to the ground faster as they do fall, and can cause them to impact the front of their heads more commonly on their foreheads. So 31% do fall on their foreheads. Temporal bones and parietal bones are the bones on the sides of our heads. And you can look at the diagram on the right there. Those are the ones that are on the side just above our ear and around our ear. So infants not only can fall straight forward onto their foreheads, the overwhelming, maybe more than 50%, 58% can be to the front or the sides of the heads. And then much more rarely, the occipital bone is the backbone of the skull, the one most to the back of our heads. Less commonly, you can see that the children will fall backwards onto their heads. And 5% or so can have multiple sites of injury. Unfortunately, almost 25%, we don't see where children fell. We don't know where it happened. Parents will just hear crying, rush over, and the child will already be on the floor. Or they fell asleep from being up so many nights with a cranky baby, and mom and dad need to get some sleep too, or it just becomes overwhelming and sleep just takes over, and something can happen without a witness of where everything happened. So on average, from these studies, also the height of the fall was about 2.25 feet, probably most likely with the child's size at that time. Maybe they fall from standing, or a low bed, or a sofa, these type of things, or even a stroller. So most of the heights are from very small distances, but for a baby that can be significant, and it doesn't take a very high distance to be able to have significant injury to the child's head. And over 80% occur under 3 feet. So it is a small distance, and obviously anything above 3 feet for that child is significant in terms of the amount of force that can be transmitted to the baby's head. So knowing the height even of a fall is very, very important. And we do have a cutoff in our medical literature that over 3 feet is a very concerning piece of history to know about a child that fell. So what are the symptoms? So this is kind of like one of the most important slides for today, in addition to what to expect at the hospital. These are the symptoms that parents, after experiencing, God forbid, their child falling, these are the things to look out for. And we'll talk about which are symptoms you need to head to the hospital with, and which are less severe, which are more mild, that maybe can warrant observation at home for a short period of time if there are no changes. So, of course, symptoms are changes that we can typically see with babies. They're not going to tell us what symptoms they have, but can be changes that necessarily we won't be able to see as a bruise on the body, but more of a behavioral change. So, of course, a child or an infant that falls can be completely asymptomatic, much more reassuring if there's no change at all to their function or how they're acting. But irritability, babies are irritable for several dozen different reasons that they don't share with us. They just do it because that's what they feel. So irritability can be from many other things, but after a fall, delayed irritability, really not completely inconsolable child for quite some time, could be a concerning finding. Sleepiness, again, babies love to sleep often, but if there is a change in the amount of sleepiness right after an injury, I argue that is one of the most concerning findings, and that goes along with loss of consciousness. Either the baby is completely out in terms of consciousness, or it can take a little time, quote unquote, sleepiness, that then can lead to that loss of consciousness as the child falls asleep. That is very concerning for two reasons. One, because that could be a sign that there's pressure on the brain and something could be evolving. And I would argue that would warrant immediately coming to the emergency room if there isn't an absolutely other perfect reason why the child stayed up all night or whatever, but I would have a very low threshold with that happening to come to the emergency room. The other concerning portion of that is that we lose our examination. You can't see how the baby is acting. You can't see, in that between those two points there, the parent reported changes in behavior. When the baby's completely out and sleeping, you can't see if they're more irritable, if they're eating the same, if they're having any other changes. So that is concerning, and that would, to me, be one of the more concerning findings to make sure that we come into the emergency room. Other signs on the physical examination, again, can show nothing, can show erythema or a redness around the area where there was contact or impact, laceration or a cut on the skin, on the head or the face. Obviously, those would be, concerning for where the point of contact was. And they require, a laceration requires a significant amount of force to open the skin. So that could be an indication of how forceful the contact was. Scalp hematoma or blood that accumulates under different layers of the skin and the scalp and the bone. We'll show on the next slide where those different layers are, so that you understand where there could be pooling of blood and understand the difference between the different layers in terms of what could have caused that to happen. We'll talk about the Glasgow Coma Scale, but essentially it's a measure of wakefulness, of language, how much sounds the baby and children are able to make, and movement of the eyes. These are very kind of straightforward, refined ways of us in the emergency room to assess the child, but there's no reason why parents can't know about it. It's not a secret. We're not keeping it as proprietary information in the medical community. You absolutely can know about it, and you can absolutely do these assessments yourself. There's nothing specific about it that requires it to be done only by a medical professional. Obviously, we want to have a medical professional confirm it to make sure that it's accurate, but you can still do these measurements very quickly, routinely at home to give you a sense of something is going on. And then, palpable skull fractures. If there is a significant fracture on the scalp, you can feel a difference between the two bones that moved. And then a bulging fontanelle. And we'll talk about what the fontanelle is and what a bulging of it means very, very shortly. So let's first get into a scalp hematoma, or a blood clot, or a collection of blood at different layers of the scalp. So the most superficial one is this caput sexudenum, which is not really a complete bleed under the skin, but it's more of a swelling. You get a bruise. That's really what we think about. And this is the name, a complicated name for a very simple thing, but essentially swelling on the scalp. And if that continues to grow and expand and becomes very disfiguring, becomes very large, that could be a reason to come into the emergency room. Below there, we have a layer that's just underneath the skin and underneath the fat that's in the dermal layer. As you have the epidermis, which is on the outside, the dermis, where our hair cells are based, where we have sweat glands, and fat underneath the very outer layer of skin. And that's where we can get a subgaleal hematoma. The galea is the layer right at the bottom of the skin layer. And there we can actually get a significant amount of blood that accumulates. And if you do continue to see an increase in a blood clot or a swelling on the scalp, that could be enough. There's enough room in that subgaleal layer to have a significant reduction in the amount of blood even circulating in the baby themselves. So the babies, compared to us, have very, very significantly less amount of blood in their bodies. So even losing a little bit in their scalp from a trauma like this could be a significant amount of blood and can have significant implications for them. We'll skip cephalohematomas for the time being and talk about the two types of bleeding we can get inside the brain. So on the covering between the skull and the brain, there's a covering of the brain called the dura, and it's durable, and that's why we call it the dura. And it separates what an epidural, outside the dural hematoma is, or a subdural, underneath the dural hematoma is. The subdural hematoma will be right on the surface of the brain, can irritate the brain and even cause seizures, and can squeeze the brain, just like on that picture on the left side, and it could cause the brain to be deformed a bit. An epidural, and that's usually from veins that are stretched between the brain and the dura, which can tear. So with veins that bleed, it's a much slower accumulation, something that we might not see in the first few minutes, but it may take an hour or two for you to start seeing symptoms in the child. So that's something to keep in mind. In contrast, an epidural hematoma is outside the covering of the brain, and it doesn't immediately contact the brain, so it won't cause seizures by contact, but it can get to a substantial size where it deforms the brain and can cause seizures there, because an epidural hematoma is from an artery bleeding, and an artery has much more pressure. An epidural hematoma can be life-threatening because of how fast that artery can bleed and how quickly that blood can accumulate there, squeezing the brain and preventing it from functioning normally. So just getting a sense of where this blood can occur is just a matter of knowing what the layers of the scalp, of the bone, of the covering of the brain are, and the blood can happen in between any of those layers. That's all it is. This I won't spend too much time on, but the Glasgow Coma Scale is, a measurement of eye movements and eye opening, movement of the body or motor responses, or verbal responses in terms of speaking and making sense with the environment. Of course, when you're talking about a child that's older and an adult, verbal responses will be very different. You get 5 points if you're making complete sense, you know where you are, and talking is not something where we're seeing any deficits. The next step down is, you're disoriented, you're confused, but you're still making normal words. Then we go down where you're making inappropriate words. A further step down, you're not even saying words, you're making sounds. And then the furthest down is you're completely mute, you're not making any response. Obviously, this is a little different for infants. As we look to the right side there, infants, we're just looking at smiling or cooing appropriately, crying but can be consoled, crying that can't be consoled, and then just making grunts or sounds to then making no sounds at all. So those, by grading that, from a scale on this Glasgow Coma Scale from 3 to 15, we can get a sense if we're in a 14 or 15 range, things are fairly okay. But if we're starting to, just getting grunts and no sounds, we've lost 3 points there. We're getting down to a 12. We're getting into a concerning area. And then with the movements, they're just moving spontaneously, they need a little pinch to move, or then just more severe kind of just reflexes and posturing where we really, really get concerned. And then finally, with eye movements, is the patient just having eyes open normally? With babies, do you need to really shout? Or with adults, do you need to give them a command to open their eyes? You lose a point if you're not just keeping your eyes open at the baseline. Then you lose another point if you really have to pinch them to really stimulate them to get their eyes to open. Or even if you're getting no response, no eye opening, that is very, very concerning. So knowing the Glasgow Coma Scale, you can look this up on Google. You don't need to memorize it to heart, but you need to know where, you're getting losses of these points to give you more concern that something is going on and maybe we should head to the emergency room immediately. We talked about skull fractures, and we talked about babies having disconnected bones when their skulls are forming. And on average, about a year of age, it'll take those sutures or the openings in between the bones to completely fuse to become solid like we have as adults. It could be up to 2 years, even 3 years. But for the most part, by a year, I see most of those sutures being closed. And it's up to us as doctors and physicians to understand when we get pictures like this, what is a suture? And if we look at column A, that one line that comes straight across where the arrow is, that goes from side to side, is a fracture. That is absolutely different. But the line that goes up and down there is a normal suture. That is absolutely a normal finding. That's the separation between the parietal bone in the front and the occipital bone towards the right of the image. And we, as clinicians, know the difference. And by looking very carefully, we can understand where there's a real fracture or there is no fracture. It's just the normal sutures. And we can't be fooled into thinking that it's a fracture. And by experience, we'll know the difference. Then, very, very, very important. I tell all of my parents to know what the fontanelle is and to assess it themselves. There is nothing special that I do when I assess it in my office. I mean, I have a very good sense of the differences in the fontanelles, and I know exactly what I'm looking for and exactly what I'm feeling for. But in terms of, it's not something special that only I can do. Parents absolutely can do that themselves. And that's where I get calls from parents so that I'm knowing about things earlier so I can help them and advise them on what they're feeling. So I always encourage my parents, in different situations, once a day, once a week, once a month, just to feel the fontanelle. And I have that image right in the middle because the fontanelle for babies is a window to the brain. As adults, we have completely solid skulls. We cannot feel anything inside of our skulls from the outside. But babies have an opening, and you can look from birth on the left side there of the image all the way to 3 months. That little diamond shape is a incomplete closure of that bone that by a year and a half is almost closed. But before it closes, when it's big like this, it allows us to feel what the pressure is like inside the skull, which is extremely important, especially after trauma. If the fontanelle is completely flat and we look at that little image in the middle with the two babies side by side, on the left, you can see that the top of the head is perfectly flat. That means if it's flat or even sunken a little bit, there's nothing putting pressure inside the skull, inside the brain. That is normal, that is healthy, that is reassuring. When babies cry, scream, bear down, they are increasing pressure in their head temporarily. We all do that. And that fontanelle can bulge up a little bit, like the diagram on the right there, and like the baby with the circle on the right side there. That bulging can be normal if it's just for momentary time that they're crying or they're straining. But if that fontanelle is bulging throughout the day and is getting bigger, and it's the baby is completely relaxed and not crying, something is going on, and especially after a trauma. So I would encourage that parents feel their fontanelle of their child multiple times after an injury. If they're not sure of whether to come to the emergency room or not, if there is even a concern, obviously just come in. But if something happens and you feel a full fontanelle, that could be an indication that something is actively putting pressure inside the baby's head, and that could be in an emergency. Come to the emergency room right when you notice that, and that is something that you are empowered to understand and feel what's going on in your child's head and inside their skull. So when should children be brought into the hospital? This is arguably the other most important slide, is when there's, to kind of summarize things for us, just to make it very refined and streamlined. Loss of consciousness. Something's going on to make the brain not function well and the baby passes out. Come to the hospital. A fall from over 3 feet onto a hard surface, like we were talking about before, that is more than what we would typically see for these type of injuries, and that could lead to more injury than would be normally seen. Come into the hospital. Inconsolable irritability. You watch your baby for 10 minutes, 20 minutes afterwards, crying. Nothing makes them better. Maybe they have an immensely strong pounding headache and they can't tell us. Come into the hospital. Seizures. That's a no-brainer, pun intended. Seizures, something's going on with the electrical activity of the brain that is not normal. You got to come into the emergency room. Lethargy, decreased activity, we'll talk about the movement of the eyes in a second, but lethargy we talked about. Same thing as loss of consciousness. Something's not going on in the brain. One of the findings of really bad pressure on children's brains, which may be not something that parents will see until it's very late. So I would hope we'd be into the hospital already. But when there's a lot of pressure on babies' brains, one little sign, a little trick for you guys to be empowered with is babies can't look up. That pressure in the brain inhibits the muscles that allow eye movement to go straight upward. So if you're noticing after a trauma, maybe with a little bit inconsolability, maybe the fontanelle is getting a little full, and you're moving the baby around, or you're moving something in front of them, and they just stop when you start going upward and they don't track it anymore, they don't look at it anymore, something could be going on there related to pressure in the brain. So another little tidbit for you guys. Obviously, if you're feeling a fracture, if you're seeing an increased hematoma or blood clot on the scalp, or an increasing bulging fontanelle when the baby's at rest, another sign something is going on. Come into the hospital. All of these symptoms and signs may represent emergencies. An urgent transfer to a pediatric emergency room can be life-saving. And we do cover at Nyack Hospital, of course. So, you are in excellent hands there, or wherever you choose to go. But please make sure that they have a pediatric emergency room, because we don't want to waste any time where they need to be transferred to another hospital. Time in emergency is brain. And the sooner we get evaluated, the sooner we can institute treatment, the better outcome we can all have. So what happens at the hospital? Okay, we have symptoms that are concerning. We have signs that are concerning. What should you expect? I mean, I don't want there to be any cloudiness, any uncertainty. Am I going to be there for 12 days? Am I going to be there for 12 hours? How do I plan my life? I have 3 other children at home. I think it's very important for you to understand what would happen there, when the doctors would send you home, when they would keep you, and how you can plan your life. I mean, I know all this stuff happens, but I know that everything else doesn't pause. So I want to give you a little sense of what to expect so you can understand how to plan things in terms of what would happen. So when you come into the hospital, obviously we need to do an exam. They're going to check the skin of the baby. They're going to check the head. They're going to make sure that the neurological examination is okay. Essentially the Glasgow Coma Scale. We're going to do those kind of evaluations. And that's going to help guide how severe or not severe the injury could be. An IV could be placed to check some labs, to give fluids, to give medications as needed. if there's any seizure activity, seizure medication may be required. And then we'll get some form of imaging of the head, and we'll go through what these different types of images are, because each one has a different role in understanding what could be going on. Either an ultrasound, which is the bottom left, an X-ray, which is one step over to the right on the images at the bottom, a CAT scan, like we have that nice 3D rendering there, and then an MRI, which shows us much more detail, and all are used for many different reasons. So an X-ray, what's an X-ray good for? An X-ray is good for a quick assessment of whether there's a skull fracture or not. From these images, you can see we don't see anything in very high detail inside the skull. We don't see the brain really. We're just looking at the bones, and we're able to see if there is a depressed fracture, meaning that the bones go inward and are pushing towards the brain, like the two images on the right where the right arrow is, or a non-depressed fracture like the one on the left. That opening towards the front of the head is a suture, so that is not a fracture. But if you start going backwards towards the back of the head, you see a very faint line over there. That's the fracture. So an X-ray can show us that. The benefits are that it's fast. You do one quick shot, even if the baby's moving, you get the shot to understand what's going on. And it's low radiation. So being on planet Earth, we get radiation just from being on this planet and having the sun send radiation towards us. So an X-ray is equal to 1 day's worth of radiation just being on Earth. When we talk about CAT scans, a CAT scan is worth a year's worth of radiation and can have implications in terms of the baby's development. We'll talk about that in a moment. Right after an X-ray, the other option is to do an ultrasound. So the ultrasound sends sound waves that bounce off of structures inside the head and then back to the receiver, and it gives us pretty good images. You can see here on what's going on inside the head. The only caveat is that ultrasounds can only be done when the fontanelle is open. Once those bones close, the ultrasound is not going to look through bone. It could only look through a fontanelle. So it's really only an option for younger babies that have large fontanelles. It's not going to show us anything about the bones if there's a bone fracture, but it will give us much more detail than an X-ray of what's going on inside the head. And on these pictures, on the left, those little brighter spots in that area where the arrow is, I mean, that's called the arrow sign. It's a medical joke we have, but clearly there's a hemorrhage there. Somebody has been nice enough to give us an arrow sign to show exactly where that bleeding is. And on the left most image, all of those dark circles, brighter circles, I should say, within the fluid, the dark fluid around it, that's all bleeding within the fluid spaces of the brain. On the right, those are the images of hydrocephalus, or an increase in the amount of fluid in the fluid spaces of the brain. Both can lead to pressure on the brain. Both can happen sometimes from trauma, even though hemorrhage is much more likely to happen. And both can be assessed by ultrasound, but only in younger children where we can get through the openings on the bones. Ultrasound has no radiation, is quick to do, can be done without sedation, and that's why we still use it, even though it doesn't give us absolutely the best picture of what's going on globally. CAT scan, unfortunately and unfortunately, provides us the best information on the bones of the skull and the best information about any bleeding in the skull. MRI, while it gives us much more detail about the brain itself, is less good, is inferior to pick up bleeding and bone changes than a CAT scan. So an MRI is not good as a first screening tool for many of these injuries. So unfortunately, a CAT scan is sometimes our go-to. Because we brought up in our medical literature our concerns about radiating children who have head trauma, we don't want to trade one problem for another by radiating them and then having, God forbid, some changes to their brains down the line in the future. We've almost universally instituted, especially at Montefiore, something called a low-dose CAT scan, whereas a normal CAT scan will have the radiation amount, as we said earlier, about a year of radiation exposure on our planet. CAT scan with low-dose radiation is significantly less radiation, ordering closer to an X-ray, and it still provides us the same amount of information of what could be going on with the skull and blood. So we've worked a way for us to use this really highly informative scan to make it as safe as possible for our children. And I know that we do that routinely at Montefiore and at Nyack. On the left there, we see a depressed skull fracture. One of the bones is wedged underneath the other one, is pushing on the brain. And on the right, we have the different types of bleedings that we can have. We talked about an epidural hematoma, that's the EDH, and we talked about a subdural hematoma, which is underneath the dura, which is the SDH there. So you can see how brightly, how quickly you can see imaging that shows bleeding when you do a CAT scan. The bone will always be very bright white on a CAT scan, but you can see that the bleeding is not as solidly white. So if you talk to an emergency room doctor or you happen to see images like this, you are empowered to know what could be blood, what is the normal bone. Obviously, the bone is only on the outside. It's not towards the brain, and anything bright in the brain could be bleeding, and empowered to know what a fracture will look like, so that when you talk to the doctors, you have in a sense of a meaningful way to talk to them and ask appropriate questions. Finally, an MRI, really great detail for the brain, but not great detail for blood, not great detail for the skull. On these images, the skull is this thin black layer between a brighter skin on the outside and the gray brain on the inside. It does show us that there's fluid surrounding the brain in the panel all the way to the left, but an ultrasound can show us the same thing, as can a CAT scan. Where an MRI comes in, if there's a stroke or death of brain tissue because it didn't get enough blood supply, or blockage of any of the blood vessels, an MRI will show that much sooner than a CAT scan would. And the other thing that a CAT scan and an MRI can show in the very bottom image there is called brain herniation. So there's a big blood a collection of blood, as we can see that bright area towards the right of the MRI. That blood is literally squeezing the brain from one side of the skull to the other. That can be life-threatening. When we see that, then I get called, and we have to do what we can to urgently manage that. So what happens at the hospital? Why do you need to know about all these things we just talked about? You guys, some of you went to medical school, of course, some of you did not. But why do we all need to be on the same page about this? Because you are your child's best advocate, whether they can speak or not. You know what's best for them, and you need to be empowered with all the best information to be able to make the best and most rational decisions for them. A picture, of course, is worth 1,000 words. You must be empowered with this knowledge to make the best decision for your child. And if you go to an emergency room somewhere else and you don't get this information, I would argue that you're not as informed as you should be to be able to get this knowledge. And that's why we're talking about it today, so that you have this as a baseline. So in my practice, it is imperative. I always review all images in detail before any decision for management can be made with the family. It's a collective decision. I need the family to understand things as I do, and I need to guide them for them to understand it as they would like to see things, so that they can make the best decision with me. If I do surgery on a patient, sometimes I will get the video and I will show the patient afterwards what we actually did, so they can understand what's happening. The more information I can provide for you, the better decision you can make with me for what we can do to help your child. What other things can happen? So a period of observation can happen if you come into the emergency room. If it's something minor, you can just be observed for a couple of hours. If it's something more serious, maybe overnight and beyond. And knowing what the findings are on the imaging studies and their neurological exam, which you now are empowered to know, will help understand which one of those will happen. Will you likely be there longer or less time? And it'll allow clinicians enough time to ensure there's no late or developing issues with patients that may have more severe injury. If the cranial imaging is completely normal, a few hours could be more than enough to send the infant home with close follow-up. If your child's exam remains strong with only a fracture that's not pushed into the bone, it's also safe to go home. And that's one of the biggest changes we had in our medical literature over the last decade or so, is that, if there's just a small skull fracture, it will heal. As long as the bones are still opposing each other, the bone will regrow, bridge that gap. You don't need to be in the hospital for that. So that's something important to know. If there's a depressed skull fracture, the bone is going towards the brain. If there's any hemorrhage inside the brain or the skull, or even anything more severe, at least overnight observation will happen. regardless of the exam. We don't want the bleeding to continue to increase. We don't want the skull fracture to go further in or cause anything. And I think parents would be in agreement that overnight observation, in the least, would be warranted in those situations. And we may need to repeat the imaging just to show that it's completely stable before we send you guys home. Any loss of consciousness, seizures, significant changes in exam, almost regardless of the imaging, with significant findings or even without, will still likely result in overnight observation. So those are the things to kind of expect. When there's a depressed skull fracture that's pressing on the brain, we may need surgery to prevent it from continuing to irritate the brain or cause bleeding on the surface of the brain. Any change in the exam with a brain hemorrhage, the baby is completely unconscious, cannot be woken up, and there's a brain hemorrhage that's putting pressure on the brain itself, we may need to go to surgery to remove that blood clot and relieve pressure on the brain. A fracture that goes down towards the brain can also open the dura and cause the spinal fluid to leak on that image we have on the right. And that's going to cause a growing collection on the outside of a big bump on the outside of the skin. May need to go to surgery. And then like we looked at on the MRI picture, a herniation of the brain or squeezing of the brain from any of these openings that it shouldn't be squeezed through could be life-threatening. And that's where an emergent life-saving surgery can be needed. And that's where you call the guy at the bottom of that slide. So scenario one, just a couple of quick scenarios. Infant A, 14 months old, fell from standing about 2 feet onto a soft carpet. Mom, dad weren't really sure if they hit their head, cried for a second, and then returned completely normal behavior. The fontanelle was checked. It was flat, soft. There's no change in the activity, no new symptoms. Do you need to go to the ER? You can. There's nothing wrong with that. But if there are absolutely no further changes, there is an option to just observe them, call your doctor, send me an email, call my office, whoever it may be, and just say, hey, this is going on. We can advise you. Okay, you watch at home. You call me back in a couple of hours. If there's no change, stay at home. We'll continue to monitor any change emergently to the emergency room. Infant B, a little bit different, 6 months old, rolled off the bed, hit their head very visibly, and lost consciousness. He awoke, but crying with a full fontanelle. It's tense, and then fell asleep 15 minutes later, and then the fontanelle became flat. So, while the fontanelle isn't constantly elevated, it shows that maybe there isn't a substantial amount of pressure, but that loss of consciousness is a little concerning. The baby now fell asleep. It's hard to maybe wake them up. Loss of consciousness, lethargy, regardless of the fontanelle, is concerning. I would still come into the emergency room in that scenario. So when you don't have a change in the Glasgow Coma Scale, the eyes are moving, baby's making sounds, and the movement of the arms and legs is normal, you can stay. Most likely, things are okay, you could probably stay at home. If the mental status is normal, you don't feel a skull fracture, you don't see a swelling or blood clot on the skull, you don't have a loss of consciousness, you have no change in the activity, the fall was less than 3 feet, there was no motor vehicle injury or anything like that, and then no more severe or more impactful injury, probably can't stay home as a kind of loose guideline to when to come in and when to not. What are the consequences? A very busy slide, but the only thing I want to point out is the right side there. With minor injury, all of these are minor. How many have significant deterioration? How many children? 0, 0, 0, 0, 0, 0, 0. So with minor injury, with none of the signs that we talked about, the chances of things getting worse is almost 0. And that's why we can stay at home and observe if there isn't any concerning signs or symptoms. And we look at kind of outcomes. We're getting into the last part of our talk. What happens with injury long term? And we use not the Glasgow Coma, the Glasgow Coma Scale. We use the Glasgow Outcome Scale, and this is a measure of what happens long term. 1 to 3 means that there's either death, significant injury to the brain, severe disability. 4 or 5, either completely normal or very minor injury, moderate disability. So we kind of split it up 1 to 3 or 4 to 5. And on this scan, it just show this slide, we just show that the initial presentation of a GCS 3 to 5 is very low, more likely to have a worse outcome long term. The Glasgow Outcome Scale from 1 to 3 is bad. Most of those children that have a very poor presentation have very poor outcomes long term. When things are a little bit better, a little higher score from 6 to 8, it's much more likely that they're going to have a good outcome long term. When there's multiple traumas, again, much more likely to have a worse outcome longer term. When it's just head injury and it's not severe, a better chance of it having a long-term good outcome. Otherwise, other early complications when you have a trauma and the heart stops, God forbid, or there's a blood clot in the lungs, there's problems breathing, these type of complications or problems with blood pressure. When you have these early complications, they're very much associated, 12 times more likely to have a bad outcome long-term. When they don't happen, you're much less likely to have a long-term problem, and things are more likely to get better. Then final, one of the last slides, what are the consequences of this? The likely you are to have an early complication. Hypoxia means a lack of good oxygen delivery to the body. Hypotension is low blood pressure and not good blood delivery throughout the body. When these things happen, you're much more likely to have a bad outcome long-term. So getting the patients to the hospital early, identifying concerning symptoms and signs, all of these are critically important to prevent these early complications from happening and give the best chances for long-term outcomes that are very, very good. This slide's a little bit busy, but talks about similarly what we talked about before. We'll skip over it for now. So what are the consequences? In general, to summarize, without the associated risk factors that we talked about previously, over 90% of patients do very well long-term. We know what factors will cause more trauma and more impact and more force to the skull. We know which ones, which signs and symptoms on exam can be associated with poor outcomes. But for the most part, thankfully, most children do very well long-term. With any concerning risk factors, we really need to immediately recognize this by exam or palpation of the fontanelle, whatever it may be, and transportation to the hospital is critical. Time is brain in certain situations. Emergent management of cardiovascular circulation, like blood pressure or increased pressure, intracranial pressure, increased pressure inside the skull, can be life-threatening, no question. And time that we just sit on things and leave things to be can cause a significant risk of death. So emergent management is very important, because even with those very serious complications, if we act quickly and correct them and prevent them from leading to permanent injury, kids can still have very, very good outcomes long-term. So that's why I want parents to call me right away as things are happening, because we start the ball rolling on what we do to manage things early on, because the earlier we are aware of things, the best chances we have of a good outcome long-term. So in conclusion, know the risk factors for serious injury after cranial trauma. I feel strongly that you guys will know this, from our talk today. Evaluate immediately and monitor closely after any injury. Have a low threshold to come to the hospital. You now know what to expect when you're there. You now know the language of the imaging and what the findings could be, to have a conversation about what's happening so you don't feel like you're lost. How long are we going to be here? What's going to happen? You're now empowered with that information. Know how to advocate for your child. Know what to expect into the emergency room. And do not blame yourself. A fall does not mean you're a bad parent. It happens. It's life, okay? The more you beat yourself up about it, the more you're going to distract yourself from doing what's urgent and important and taking care of the child in that moment. It happened. Don't worry. You're not going to be arrested by ACS. We know when abuse happens, when accidents happen, we will always advocate and be on your side and help you through this very difficult time. And yeah, lastly, no, don't just think maybe or whatever. Absolutely 100% certainty. No, there are many great doctors here at NIAC, at Montefiore, to help you when you or your family needs it. We are always available for you. So protect those heads. So we need to make sure our next generation of, if they choose to be doctors, are protected, and we give them the best chances, even if they had an injury to their brain early on. All right, so thank you all very, very much for your time and attention. Feel free to email me or call me anytime. That is my direct email. I check it, at least a couple of times per day. That number, please write it down. That's a direct number to my office, to my secretary, Danny, who loves to talk to our patients and will be more than happy to help you. Either get in touch with me directly if it's an emergency, or help guide you on how we can, see you in the clinic. So again, thank you everybody for your time and attention. Thank you, Sandra, for this opportunity. It's been a real privilege to talk to everybody, and we are here always to help you in even these most critical times for you and your child.
And thank you, Dr. Kobets, for this very, very important information. This is, it's a lot, and I'm glad that we are recording it. That way we can go back and back to the recording, because this is definitely, especially for those of you who have small children, this is vital information. And this can be the difference between, you know, saving a life or not. And this is great directives for a lot of parents. I'm just going to make two questions in the interest of time, but we have a very important question here. It says, a family friend, 19-year-old, crashed his scooter into a tree. He cannot see from his right eye. He did see a doctor and was told they don't know why, as they say, back of the eye is fine. Just wondering if he should seek a second opinion.
So he crashed into a tree, and then the part about the eye, I didn't hear you completely. What was it?
He cannot see from his right eye, I believe, as a consequence of an injury. He went to see a doctor. They looked at the back of the eye. They said it's fine.
Was it so? I would urge a neuro-ophthalmologist or an ophthalmologist, a specialist, to see the eye. Obviously, you know, there could be issues that are just within the eye themselves. The globe could be ruptured. There could be a detachment of the retina or the layer of cells that provide vision at the back of the eye. When they looked into his eye, they wanted to make sure that there was nothing inside the skull that was pushing the eye forward from pressure in the skull. If that's the only thing going on, you know, it makes it less likely that there could be a major injury to the brain itself. But that's not 100%. You know, that's not 100%. And the fact that he's having a significant neurological change with vision, a loss in his eye, I would urge him to go to the doctor and get an imaging study to further evaluate, and a neuro-ophthalmologist to evaluate him as well. I mean, if he wants to come, call my office. I'll see him next week, and we can set all this stuff up. But I'm concerned about that. I mean, he's young. He's 19. He can't live without loss of his right eye vision if there's something we can do for him. So, you know, if there is something to do, we need to get the pictures to understand what's happening first, and then we can go from there.
Yeah, so I'm sure that they will make an appointment to see you, Dr. Kobets. So just make sure when you call the office that you mentioned that, you know, we had this discussion in community chats. That way, Dr. Kobets is going to know who you are. I don't want to say the name loud because I respect people's privacy here, but that's very important. So thank you for bringing that up. And then one more question is, you were talking about all the different signs that we should look for at home for our children after they fell or whatever happened. For how long do you have to be watching those signs? I guess 5 hours, 6 hours, after 12 hours, you can be sure it's okay. How long?
So part of the answer to that is, no matter what I say, mom and dad are going to be on the baby like a hawk, no matter what. But you know, it's a question about picking up like a very low threshold to pick things up, or a very high threshold where you can miss things. But you know, what parent is going to want to say, oh yeah, 2 hours, no big deal, I'm just going to like not watch them anymore. You know, parents are going to be on them like hawks no matter what. You know, as a kind of a general broad, you know, rule to make sure that we are as sensitive as possible to pick up anything, I would say at least 24 hours. And that's why we do overnight observation in the hospital like that. At least overnight, you want to wake up in the morning, you know, come back to normal function. So if that's done in the hospital or at home, I would at least give it a 24-hour observation period, very close observation.
Okay. And Dr. Kobets, to me, it was very interesting when you were describing the coma scores and how quickly they start going down and all of that. So when you said something interesting, you said if your child is sleepy and would not wake up, right? Like, how do you know the difference between my child being very sleepy and getting into a coma state?
Yeah, so you know, we'll get a fall from bed, and you come in at two in the morning in the emergency room, and I see the baby asleep. I mean, we have to have a little common sense there to know that, you know, babies are going to sleep at that time in the morning. Part of it is going to be, you know, I know medical consequences, and I know surgical indications, and I know what to look for, with in regard to my training. But what I don't know is your specific child's details of how they are, how they sleep, how they function. That's where we come together. That's where we have information sharing. And you need to let me know what your child is like. What do they always are a very sound sleeper and nothing wakes them up, or the opposite? So, your mom and dad are going to have a sense that this is not normal or not. But any baby that, we give a little pinch to or whatever, we can't wake up, I would be very cautious about that. And that's where we kind of work together to understand whether this is totally far from normal, like our baby wakes up at the drop of a pin, or, baby will not wake up no matter what. But even in then, we have to use a little bit of common sense, but a very low threshold to not just say, oh, it's okay, it's okay, it's okay, and God forbid, miss something that could be going on.
Yeah. Well, Dr. Kobets, I wish I had met you years ago, because now my daughter is 19.
I see one more comment from Edith. I can't see her last name for some reason. Oh, sorry. We'll just keep it as first name. It's Edith.
Yeah.
I appreciate your comment very, very much, and I would encourage you, please send me an email, and I will be more than happy. I love to do outreach, especially for students like this. So I would be more than happy to be involved.
Yeah, and I think Edith brings a very good point, and it's the importance for teachers to know this information as well, because a lot of accidents can happen in the schools, and they usually, take the time to call the parent, and we're wasting time there. So definitely we're going to start reaching out to schools. And Dr. Kobets, I'm afraid I'm going to be giving you lots of work after this, but it's going to be okay.
Happy to help. I think next month we have another talk coming up as well.
Yes.
Maybe mini advertisement talking about normal development in children, not necessarily from any acute injury or trauma, but signs of milestones of what child should be meeting, different milestones and developmental progress at certain points in age, and when things are going a little off, and when things need to be alerted to their primary care doctors or a neurologist or even a neurosurgeon. So very excited about that talk as well. And thank you, Sandra, again for the opportunity to talk again.
No, thank you. And next week, for all of our attendees, we're going to keep talking about this part of the body, because we're going to also be talking about migraines. So I know a lot of us suffer from that. So migraines next week, and then we're going to have again Dr. Kobets next month, and the schedule for August will be going out soon. Dr. Kobets, such a pleasure to have you today. I learned so much, and I'm sure our attendees did too. And we're going to be talking about this presentation for a long time, I'm sure. And I will see you everyone next week. Thank you for being with us. Bye-bye.
Thank you, everybody. Thanks for joining.